Started. Good morning, everybody. I'm Debbie Emerson, Hope Hospice's community health educator, and I'm the facilitator of the Family Caregiver Education Series. And in addition to my many years experience as a health educator, I also have a lot of experience as a family caregiver. So my goal today, as in all of my presentations, is to bring to you information that's based not only on my professional training and experience, but also on my personal experience as a family caregiver. And in the past, I have mostly focused on experiences with parents and in-laws, caregiving for them. But about a year and a half ago, I had an accident and I ended up, hospitalized, and it was not a good experience. And it very definitely validated my views of the importance of, advocating for others, but also being able to advocate for yourselves. I wasn't able to advocate for myself because I wasn't in a really great position. And what I learned after the fact was I really should have educated my husband and maybe even my adult kids on the importance of advocating. And so that was a hard lesson to learn, but I'm hoping that I'm going to be able to share some of those experiences with you, and hopefully you can learn from my experiences. So here's today's agenda. I'm going to start with the importance of using effective communication skills, followed by tips for organizing and managing personal health information. I'll cover hospitalizations and the rights and responsibilities of care partners. Now, the discharge process and planning for follow-up care, it can be really stressful. So there's so many decisions that need to be made at this time. So I'm going to try to give you some guidance to help you better manage this while hopefully keeping your sanity and protecting your rights. By the way, I'm going to assume that most of you are caring for someone who's on Medicare. Now, while I'll address some other insurance plans, much of the presentation does focus on your rights under Medicare. Okay, the word advocate, when used as a noun, is a person who speaks or writes in defense of another person or cause. So an advocate is someone who has your back, so to speak. They're there to help you at times when you may not be able to help yourself. Now, as care partners, being an advocate for our loved one is one of our most important jobs. The key to being an effective advocate is to use good communication skills. Now, there are 4 basic communication styles, and I am sure that you have heard all about these. But I always think it's a good idea to refresh our memories because if you're like me, under stressful situations, I tend to revert to the less effective styles. Okay, so passive communicators are those who have difficulty expressing their wishes, their needs, or their opinions. They don't stand up for their rights. They tend to allow others to run the show. We can show our passivity not only by the words that we use, but by our tone of voice and by our body language. We project that we're weak, and it's harder for us to get what we want. The flip side of a passive communicator is an aggressive one. These individuals express their feelings and opinions, and they advocate for their needs in a way that violates the rights of others. Thus, aggressive communicators, they're the bullies. They use humiliation to control others. And not only are their words aggressive, but their tone of voice and body language also project this. Aggressive communicators, they're not good listeners. They don't feel like they need to be because others don't matter, and it's all about them. Passive aggressive, this is the style in which the individuals appear cooperative and agreeable on the surface, but they may purposefully try to anger or disrupt. So if I'm behaving passive aggressively, I may act like everything is fine and all sweet and submissive, but I'm going to write the nastiest Yelp review ever, or try to sabotage you in some other way to get even. My facial expressions may not match how I really feel. I may be smiling, but on the inside, I'm really ticked off. So the passive aggressive communicator really never learns how to communicate in a way that respects themselves or respects others. Now, assertive communicators, clearly state their opinions and feelings, and they firmly advocate for their rights and needs without violating the rights of others. And this is the big difference between assertive and aggressive. Assertive individuals value themselves, their time, and their own needs. They are strong advocates for themselves while being very respectful of the rights of others. They listen well without interrupting. They make good eye contact. They have a relaxed posture. They speak clearly and honestly. Everything about them shows that not only do they respect you and value what you have to say, but they respect themselves. So, of course, being assertive is the best option, right? Because being assertive allows us to take care of ourselves. It's fundamental for good mental health and healthy relationships. So I don't know about you, but there are times when I've used all of the ineffective communication styles. Even though I know that being assertive is the best, there are times in my life when I can struggle with that. I've found that the style of communication that I use is affected by the situation. In circumstances where I feel confident, it's pretty easy for me to be assertive. But if I'm feeling insecure, my passive side tends to come out. When emotions are high and I'm feeling stressed, that's when I can lean toward being aggressive. Now, I'm not proud of this. When I was caring for my mom and I felt like her needs were not being met and I was really stressed out, well, that's when Mama Bear surfaced. And I had to remind myself that to be a good advocate for her and myself, I needed to breathe and tell myself that being angry and aggressive was actually doing us both more harm than good. Now, our general temperament can influence our communication styles. Some of us are type A personalities. We're quick to rile, we're overly active, high strung. Others are, by nature, more easygoing and mellow. And if we've established a particular communication style in the past and feel as if it's worked for us, maybe even if it didn't really respect others or ourselves, we may default to that style. And even though it might have worked for us in the past, once we become advocates for our loved ones, really the best way to go is to try to be assertive. So are we stuck? Are we doomed by our past patterns? I don't think so. Try to identify the triggers that can cause you to be aggressive or passive. If you know, for example, that strong authority figures can make you feel inferior, remind yourself that you and your needs are just as important, and you deserve to be respected and heard. And practice, maybe just in your head. Or if you've been in a situation where you didn't communicate as effectively as you wished you had, replay the situation and try to come up with a better reaction or a response. Because I really believe that we can learn to be better communicators. And remember, being assertive means we can clearly state our opinions and our feelings. We can firmly advocate for our own rights and needs without violating the rights of others. And always remember that listening is just as important as speaking. So, how well you communicate with healthcare professionals is one of the most important strategies for getting good healthcare. But sometimes that's not always easy. In the past, the doctor tended to take the lead and the patient followed. But today, a good patient-doctor relationship is more of a partnership. And you, as the family caregiver and advocate for your loved one, you're essential to that partnership. Now, actually, it's more like a team that also includes nurses, physician assistants, pharmacists, and all the other healthcare professionals involved. Good teamwork is necessary to manage medical problems and to keep your loved one healthy. Now, establishing a good partnership can begin with assertive, respectful communication. Let the physician know that you are there not only to help your loved one with their needs, but you're there to help the physician. The doctor is the medical expert, but you are the expert with regard to your loved ones, their history. You know their abilities, and you also know what they need. And you know the best way to communicate with them. And remember, with assertive communication skills, we treat others with the respect that they deserve. But our demeanor, our good listening skills, our patience, our sincere interest show the healthcare professional that we too are worthy of respect. And the family caregiver's role is just as important as anyone else on the team. Healthcare professionals can't do their jobs unless we're honest. This is especially true if you're reporting on signs of cognitive decline. By the way, you may want to talk with your loved one's doctor about issues regarding dementia at a private appointment or phone call. This is an area where complete honesty is essential. You need to be able to describe those signs and symptoms without fear of upsetting your loved one. If the physician says that she can't discuss your loved one's case with you because of HIPAA, well, that's not entirely accurate. And we're going to talk about HIPAA in just a little bit. And this brings up actually another potentially sensitive area for caregivers. Most medical professionals prefer to talk directly to their patients. Now, this is important for a couple of reasons. Doctors rely heavily on their powers of observation. They want to hear directly from their patients. They want to see how the patient reacts and responds. And they assume that the best person to report on healthcare matters is that person. And speaking directly to the patient also is a sign of respect. Some patients can get petulant and angry if their spouse or adult child is talking for them. It can be humiliating to an adult if others assume that they can no longer speak for themselves. So we as caregivers, we need to be especially sensitive to that. I remember the first couple of times I took my mom to ER or a new doctor, the doctor would ask direct questions of my mom. And this was hard because her answers tended to be inaccurate. Remember, she had dementia. But having been an ER nurse, she was highly believable because she could still talk the talk. But her inaccuracies would not result in her getting the care that she needed. So I would try to slyly get the attention of the doctor and kind of shake my head, no, but it was hard. I didn't want to totally contradict my mom. I didn't want to risk embarrassing her, but neither did I want the doctor to get the wrong information. So I found a solution that worked really well in our case. Since my mom had a rather complicated medical history, every time she had a hospitalization or went to a new doctor, we had a ton of information to share. So I began putting all of the pertinent info on a sheet of paper, a brief medical history. And I'll talk more about this on the next slide. I kept this information on my computer and I updated it after each appointment or hospitalization. And I always kept a hard copy of this in my car because we never knew when an emergency would arise. I showed the document to my mom and I told her, Mom, every time we have to go to a doctor or to a hospital, they always ask us the same questions over and over. And I know that we both have a hard time remembering everything. So from now on, when they start with the questions, I'm just going to hand them all the answers. I'm sure they're still going to want to talk to you, but this way we can get all of the history stuff out of the way. Now, she loved this solution. It respected her dignity. I loved it because I was having a hard time remembering as well. And the physicians and nurses loved it because it saved time. Speaking of time, always be brief and to the point when sharing information. As this little graphic says, you only have about 18 seconds before a doctor will interrupt you. Now, it's not because they're rude and impatient. It's because insurance companies, including Medicare, regulate how much time they can spend with a patient. So you have to plan in advance what you're going to say during the appointment. Try to stick to the important details. If the doctor needs more information, they're going to ask for it. Now, that being said, make sure that you always ask questions, or if the explanations or instructions are unclear, always feel free to bring up issues that you think are important. And be sure to let the doctor know if you have concerns about a particular treatment or a new symptom that may have cropped up. So, second opinions. My mom hated going for second opinions because she felt that it was disrespectful and she didn't want to hurt her doctor's feelings. She didn't want him to think that she didn't trust him. But hearing the views of two different doctors, it can really help you decide what's best for you, especially when it's a serious diagnosis or when surgery might be involved. In fact, your insurance plan may require it. By the way, that's the excuse I always used with my mom. Doctors are used to this practice, and most will not be insulted by your request for a second opinion. Your doctor may even be able to suggest other physicians who can review your case. Now, always remember to check first with your insurance provider to find out if a second opinion is covered under your policy. And also check to see if the new doctor is in your insurance network, if you have a Medicare Advantage plan or another HMO. And see if you need a referral from your primary doctor. By the way, Medicare will almost always cover a second opinion. Okay, I have rattled on about this long enough. There's so much more to cover on this particular topic. So I have a resource for you. One of my favorite booklets is from the National Institutes of Health, and it's called Tips for Talking with Your Doctor. The title says doctor, but the booklet is really about communicating with all the healthcare professionals. I strongly recommend that you either download the PDF or, if you prefer, you can order a free booklet. So just go to the link on my resource list. And the booklet is directed towards the patient, but I have found that it's invaluable for family caregivers. It can really help to make our jobs easier. Okay, I mentioned the brief medical history that I kept from my mom. So it's essential that you always keep all of your loved one's personal health records up to date and accessible. The form that I used wasn't complicated. It was simply a Word doc that I typed up on my computer. On the next slide, I'll share some fancier ways of managing information, but the most important thing is to use an organizational system that works for you. Now, the identification section is self-explanatory, but just a note about the phone number. I never gave out my mom's phone number because I never wanted a healthcare professional to call her. Because she had dementia, it was important that I received all the important phone calls, emails, and written correspondence. So I always listed my complete contact information. Now, I did list the name of the skilled nursing facility where she was residing the last few months of her life, so it would be clear that that's where she lived, but no other details. I tried to make it clear that all verbal and written information needed to be relayed to me. It goes without saying you need to keep your health insurance information current. Medicare is pretty static, but your supplement plans tend to change. Also be sure that healthcare providers know if someone is on Medi-Cal. I always took pictures of my mom's insurance cards and I always kept them in my phone. Now, the important legal documents include advance directives and powers of attorney. And you need to have copies of these available to give to the hospital or new practitioners, but be sure to keep the originals in a safe place. It's always good to have a couple of extra copies. And it's fine to keep these records and files on your computer, but be sure that they can be found by a family member should you be out of commission. And one of the women in my support group recently had a really frustrating experience with just this. She couldn't get to the password that she needed. It's important to have an updated list of medications, and be sure to include the dosage and the reason for prescribing, because sometimes physicians can prescribe a medication for what's called off-label use, and that's a use different from what it was originally approved for. Include the date it was prescribed, and also list all meds that were discontinued. This is going to tell the physician that a particular medication has already been tried. Always list over-the-counter meds that are taken regularly, such as Tylenol, antacids, laxatives, etc. Also list any vitamins or other supplements. Now, with medical marijuana being legal, many people are using THC or CBD for a variety of reasons. So be sure to list these. And of course, it's essential to list any drug or food allergies or sensitivities. Include all hospitalizations that are relevant. You can probably skip a tonsillectomy at age 10, but any surgeries, ER visits, outpatient treatments, or medical procedures should be included. And also, if your loved one has any implanted devices, make sure you include those. And then dates and names of specialists are always really helpful. The system that I used many years ago wasn't computer-based, mostly because they really didn't exist then, or I probably wasn't aware of them. But today, there's all kinds of online systems and apps that can be helpful, as long as you're comfortable using them. And I've listed a few in case you want to check out some of them. Now, Goo Patient, which is from Google, it's a good one, but it's fairly high tech, and it actually acts more like a patient portal. But some of you may feel comfortable using that. Caring Village and Iana Care are health-based apps for family caregivers. Both of these are really excellent. By the way, Iana is an anagram for I am not alone. But my very favorite resource and personal health management system is called Next Step in Care. And this is a site from a nonprofit medical organization. It's a one-stop center for everything that a caregiver and a patient needs. They have more checklists and fillable forms than I ever could have imagined were necessary. And you can just pick and choose the ones that pertain to your situation. They also have videos and excellent resources. Honestly, I use Next Step in Care all the time when I'm putting together my classes, including this one. And you may not be able to read this real clearly, but I wanted to show you just an example of one of the fillable forms on the Next Step site. This is their medication management form. Again, it may be hard for you to read all the details on the screen, but I do encourage you to check it out on their site. What I like about this is that you can type your own info into the blue boxes. You can save it, you can print it out, should you want to do so. So it's a living document that can be updated and changed really easily at any time. So it's very easy to use. It's great to share with other family members. Now, one of the things that I really like about Next Step in Care is that you don't have to be a medical expert or a technical genius to use it. So most of us are familiar with the digital versions of our health records. These are managed by our healthcare systems. Kaiser, Sutter, Anthem Blue Cross, John Muir Health are all examples of providers that use these electronic health records. These records, or patient portals, can all be convenient and relatively easy to use. However, I do have one caveat. All of your information is protected when it's on the practitioner's or the facility's site, and all of their software is HIPAA compliant. But once it's downloaded onto your computer or your smartphone, it's up to you to be sure that your devices are protected with some antivirus software. So always read the terms of service and the privacy policy very carefully before storing your data. Some of the non-HIPAA covered personal health records, they market your data. So make sure that you have the right to delete your record, if you choose to do so. So if you're using a wireless connection, as most of us do, be sure it's encrypted. So look for that small lock symbol in the upper right-hand corner of the screen. However, the lock icon doesn't necessarily mean that the website is 100% safe. Hackers are getting more and more sophisticated and using these icons and security notations. So never enter sensitive information, like your social security number, your Medicare ID, credit card info, unless you are sure of the link. And kind of goes without saying, we're hearing this a lot, it's really important. Never click on a link from an email unless you have asked that the source contact you. And definitely never click on a link from a text message. The hackers are getting more devious. Two close friends with just in the last 2 weeks have both been victims of identity theft. And it's been a nightmare for both of them. Keep a printed copy of your personal health records just in case the records get deleted or altered. And then always double check the information on your personal health record to make sure that it's accurate and up to date. So it goes without saying, we don't go to hospitals for a good time. And there's always a crisis situation, a stroke, heart attack, serious illness, falls, injuries. And everything about them, at least in my opinion, is distressing, especially to an elderly person and to one with dementia. Hospitals just confound existing impairments, vision and hearing issues, incontinence, problems with mobility, and again, dementia. And hospital care has changed a lot in the past 20 or 30 years. Patients are now admitted only for serious injuries or illnesses. They stay for shorter times, and many are discharged when their condition is stable, but before they're fully recovered. And discharges often happen with little advance notice. As a family caregiver, you may have had this experience. Sadly, for those of us caring for an elderly loved one, a hospitalization, whether it be planned or an emergency, is not a matter of if, but when. So the best way that I can help you to help yourself is to stress the importance of advanced preparation. Now, I've talked a lot today about having all the important information and documents ready to go at a moment's notice. By the way, don't assume that the hospital or other medical facility has all of this information in their database. And even if they do have some of it, they're still going to ask you a bajillion questions, and their information may not be up to date. So in addition to having the Advanced Healthcare Directive that lists the healthcare proxy or agent and the power of attorney, you also need to submit a form from Medicare, and it's called Medicare's Authorization to Disclose Personal Information. Otherwise, Medicare may not talk to you, especially on the phone. So having a power of attorney isn't good enough. And I do have a link on my resource list where you can get a copy of that Medicare form. Now, I got in the habit of double checking that hospitals had the most current information about the insurance after a bad experience with my mother-in-law. And always make sure they have an accurate cell phone number for you. Another bad experience, this time with my husband's hospitalization. So again, it's always good to check and double check and never assume anything. And I can't stress enough the importance of knowing your rights and responsibilities and where to go for help. So let's take a look at that. So you may not have known that as a family caregiver, you have rights. The California Hospital and Family Caregiver Law was enacted in 2017. It was originally called the CARE Act, and it's still called that in other states, but not in California. CARE stands for Caregiver Access, Record, and Enable. So when a patient's admitted to a hospital, either the admitting clerk or nurse must offer the opportunity to record the name of a family caregiver in the patient's medical record. This is especially important when a patient is elderly or has dementia. The hospital must keep the caregiver informed of all discharge plans. I'll talk more about this in just a minute. And the law stipulates that the hospital must provide education and instruction about any necessary aftercare tasks that the caregiver will perform at home, including medication management, injections, wound care, how to safely move the person from one space to another. I sure wish this was in place when I was caring for my mom. Life would have been so much easier. So because the law is relatively new, you may encounter individuals or facilities that are not aware of it. So AARP has made these wallet cards available for every state, just in case you need a reminder or some backup in case someone is questioning your rights as a family caregiver. And I do have a link to these cards on my resource list. We've all heard about HIPAA, the federal law designed to protect our medical information from unauthorized use. It's also designed to help healthcare agencies share information with each other. It was actually supposed to expedite the process of sharing and protection, but most of us know that it seems to generate a lot of forms that we have to sign. And as a result, most of us don't even read all of the forms that are shoved under our noses. I know I'm guilty of that sometimes too. And many people, even healthcare professionals, aren't totally up to speed on what you can and can't do under HIPAA. So overall, HIPAA is intended to balance a person's right to privacy with the need for health providers to communicate with each other. And the goal was to provide proper care for patients and to act in their best interest. Now, the privacy rule part of HIPAA gives you rights over your health information, and it sets rules and limits on who can look at and receive your health information. The privacy rule applies to all forms of your protected health information, whether it be electronic, written, or verbal. If you request it, your doctors must give you copies of your health information. This is known as the right of access. And you also have the right to review and correct any erroneous information on your medical records. This last big bullet point is really important for family caregivers. HIPAA does not prevent healthcare providers from sharing a patient's information with the family if the patient doesn't object. And in some cases, physicians or other providers can use their professional judgment to determine that the patient does not object. And this typically comes into play when dealing with a person who has dementia or is otherwise, cognitively incapacitated. The information can also be shared with any family members who are involved in managing a loved one's health care or who are responsible for paying the bills. So if a provider tells you, the caregiver, that HIPAA prevents them from sharing your loved one's info with you, they may not be up to speed on what the privacy rule is all about. And this is where you can use your excellent diplomatic and assertive communication skills to help educate them. HIPAA is really complicated. So for more information, check out the HIPAA link on my resource list. And that particular resource is designed specifically for lay people like you and me. So unless the hospitalization has been scheduled, patients frequently are admitted to the hospital via the emergency room. And most of us know what emergency room waiting rooms are like. They tend to be loud, crowded, overstimulating, and sometimes frightening. Also, for the dementia patient, the unfamiliarity of the situation can cause further agitation and confusion. Now, there's a lack of privacy, and it's distressing to see or hear others in pain. The wait always seems to be excessive. Hospitals have to triage the patients, and of course, the ones with the most serious conditions are seen first. So here's a few strategies that worked for me most of the time. So I learned that when my mom went to the ER via transport, either an ambulance or a medical transport that we hired, she didn't have to wait in the waiting room. Now, she didn't always get taken into a room, but even waiting on a gurney in the emergency department was better than the waiting room. By the way, if someone is transported to the hospital via ambulance and then admitted, insurance usually picks up the bill. Medical transports are paid out of pocket. They're pricey, they depend on the distance, but for me, medical transports were worth it. I didn't have to run the risk of driving my mom to the hospital myself if I didn't think calling 911 was in order. And also, as I said, in most cases, it allows you to avoid that dreaded waiting room. Now, we had a better chance of being seen sooner if I made sure that I shared all of her medical conditions with the admitting clerk. So I always mentioned that she had a history of stroke and had 2 heart attacks. I wanted her to be bumped up on that triage list. And I also let them know that she had dementia and that everything needed to go through me. Now, this is the time to be sure that your name and contact number are recorded on the chart. I learned to always have a little headset and her favorite music on my phone. You may want to have other distractions on hand as well, an iPad with family photos, some kind of a little game to play, whatever might work to keep your loved one calm and distracted. I always had to remind myself to breathe. My mom was an emotional sponge, and she would soak up my emotions and my disposition. And if I was stressed, she would be too. And I had to constantly remind myself that what I considered to be an emergency, such as my mom needing to use the restroom, like now, was not considered to be a real emergency. Now, the staff is dealing with gunshots and strokes and serious accidents. Not a biggie to them if my mom had a little accident. So here are a few more tips. While there may be several family members who are concerned about the patient's well-being while hospitalized, for the sake of reducing confusion, it's best to designate just one family member as the point of contact. Unless the primary care physician was the one who suggested a hospitalization or ER visit, they may not know that the patient's been hospitalized and that the hospital won't automatically contact them. So even if you put the name in the record of the primary care physician, it doesn't always happen. So make sure that you call the primary care, just in case, to let them know that your loved one has been hospitalized. They can be a good ally for you. Now, many hospitals have hospitalists on staff. And these are physicians who manage the care of hospitalized patients, but who do not have their own private practice in the community. So ask the hospital nurse or the social worker for help if you're not sure which doctor is the hospitalist assigned to your case. Typically they'll introduce themselves to you. So the hospitalist can serve as a liaison between the hospital and the patient's primary care physician. They should update the primary care physician about why the patient was admitted, what tests were done, what results are still pending, and any medications that were changed. And I discovered that hospitalists frequently have way more time to talk with you. The squeaky wheel. I always made sure that I introduced myself to the staff. I tried to be as much of a help as I could to them with regard to providing care for my mom. And I always wanted them to know that I was a part of her care team. Now, remember, it is your right to ask questions and to see all records and test results. I tried to stay informed, but I also made every effort not to interfere with what the staff was doing. So even though my mom's dementia diagnosis was in her chart, I always tried to let the staff know about strategies that worked well with her. She had vascular dementia, and she had a lot of abilities left. Since her social abilities were still very much intact, others didn't understand that her short-term memory was impaired and that she had a hard time following directions. She couldn't remember where her call light was, nor could she remember what it was for. She also had macular degeneration and was hearing impaired, but you wouldn't know this just by looking at her because she did a great job of compensating. So it was really important that I was always there to advocate for her. And something I wish I had known years ago when I was my mom's family caregiver, where to go for help in the hospital. Typically, there's a medical social worker assigned to each floor of the hospital. While these individuals are employed by the hospital, their job is to make sure that the patient's needs are being met. And they often may serve as the discharge planner. And then every hospital has a patient relations department, although that name varies. Patient relations liaisons, they work with hospital patients and their families to address any concerns or special needs. They also work directly with administrators to solve patient and family problems. They can also be called patient advocates. So if you have any concerns about the quality of care, ask how to get in touch with this particular department. And later in the presentation, I'm going to be talking more about other resources for advocacy. So after a stint in the ER, the patient may be admitted. And there are two categories of hospital patients in patient care: inpatient and outpatient. Now, with inpatient status, you are formally admitted with a doctor's order. A patient must meet certain criteria that are established by Medicare to be admitted as an inpatient. And all inpatient costs, including care, tests, procedures, treatments, medications, those are covered by Medicare Part A. Observation status is supposed to be used temporarily while the doctor decides whether a person should be admitted to the hospital as an inpatient. The patient will receive appropriate care and then discharged when the team feels that they're safe to leave the hospital. Now, this care may be given in the ER, or the patient may be moved to a hospital room. Medicare Part B covers observation status because the patient is considered to be an outpatient. Now, most people assume that they're an inpatient at a hospital when they stay overnight. But increasingly, that may not be true. Recently, hospitals have been classifying more patients as outpatients or on observation for overnight stays. I'll give you a little bit more on that later. It's supposed to be temporary, but sometimes hospitalized patients stay in observation status for many days. My recent experience, I was an outpatient on observation, and I was 2 nights and 3 days in the hospital. So why is this? Observation status is used by hospitals to avoid losing money, to avoid accruing financial penalties, and being accused of Medicare fraud. Hospitals get penalized by Medicare if they admit a patient, discharge him in a few days, possibly prematurely, only to have him be readmitted less than 30 days later. So to get around the Medicare penalty, hospitals began using the outpatient status. However, this status seriously affects Medicare beneficiaries' access to care and coverage. I'm going to go into more detail about this because it's really important. So how can observation status adversely affect a patient? There are higher out-of-pocket costs because Medicare Part B is responsible for outpatient services, and it pays differently than Medicare Part A. You're going to have higher copays and deductibles. Remember, observation is considered to be outpatient, even if you're in a hospital room. The other huge issue with observation status is if the patient needs skilled nursing care after discharge. In that case, Medicare will only cover the first 100 days of care if the patient has inpatient status for at least a 3-night stay. In hospital jargon, this is referred to as 3 midnights. Skilled nursing home care is only paid by Medicare if the patient requires medically necessary treatment. That is, not just custodial care, such as assistance with eating, dressing, bathing, walking, etc., and only if they are discharged to a skilled nursing facility after a 3-night inpatient hospital stay. So some Medicare Advantage plans like Kaiser and also Medi-Cal, they have different guidelines. They tend to be a little bit more lenient. Medi-Cal only requires 2 midnights. So ask the staff to confirm admission status and make a written note of each person's response, their name, position, and date. And while you can't formally appeal admission status, you can request that it be changed. So your best chance is to ask the patient's primary care physician to talk to the hospital physician. Ask them to intervene on the patient's behalf. They know the medical history, they speak the same medical jargon as the hospital physician. The patient's own doctor might be able to convince the hospital physician that the hospital status should be changed from observation to inpatient. Especially if the writing on the wall indicates that the patient will ultimately need skilled nursing care upon discharge. The hospital can retroactively change the patient's status from outpatient to inpatient, but this change needs to be made while the patient is still in the hospital, and it needs to be done with written notification. So again, if it looks like skilled nursing care is in the picture, a status change is really worth fighting for. Another big expense with observation status is who pays for the medications. When the patient is in for observation, not all of the medications are covered, just IV drugs and the ones that are directly associated with the reason for admittance and that are prescribed during the hospital stay. So, there's something called self-administered medications. And these are any medications that the patient has been previously prescribed. And this also includes over-the-counter meds. If any of these meds are not related to that current hospital stay, then they're not going to be covered by Medicare Part B. So let's say a person is hospitalized for intense abdominal pain. If that person regularly takes a medication for, let's say, high blood pressure, and another one, maybe Symbicort for COPD, neither of those meds will be paid for because they're not related to the intestinal issue. And you're not supposed to bring your own prescriptions. So the hospital pharmacy will supply those meds, and you will have to pay out of pocket for them, usually at prices much higher than you normally pay. So if, for example, you take Tylenol for your arthritis pain, but you're not in the hospital for arthritis, the hospital can charge you an exorbitant amount for the Tylenol. Now, these hospital-supplied medications that fall into the self-administered category, they can often run into the thousands for just a day or two stay, especially if the patient has a lot of meds. Because not only are you charged for the actual medication, but you're charged because the nursing staff needs to give them to you. Even though they're called self-administered, never made sense to me. Now, if you have a Medicare prescription drug plan, known as Medicare Part D, that plan may cover your self-administered meds. And here's how that usually works. The patient will pay up front when they get their hospital bill, and then they submit a request for reimbursement to the Medicare prescription drug plan and hope that they will pay. And by the way, when I was in this situation, my Part D plan would not pay. And I'll tell you more about that in a moment. Some Medicare Advantage plans have different coverage, so be sure to check. The best person to ask is your nurse case manager or the hospital social worker. Now, good news for the person with Medi-Cal as their insurance. They can't be billed for any copays or deductibles. Can you bring your own prescriptions and over-the-counter meds, such as Tylenol? Now, the protocols vary from hospital to hospital, so it's always important to ask. You'll need the hospital's pharmacy to verify your meds. In other words, you'll have to hand them over and they're going to have to take a look at them. They may or may not do so, most likely not. And remember, if the nursing staff administers your meds, in other words, they hand them to you, you're going to be charged for that service. So I recently experienced this firsthand. I thought I was going in for a 1-hour outpatient surgery to repair a fractured kneecap. But due to adverse effects from mismanaged anesthesia, I was admitted for what turned out to be that 3-day stay. Since I had been given way too many pain pills and IV pain meds as a result of the anesthesia mishap, I was delirious. I had no idea what was happening. Thus, I was unable to ask questions and advocate for myself. And of course, I foolishly had never taught my husband what to do. So we were at the mercy of the hospital. Since I was assigned to a regular hospital room, neither my husband nor I realized that I'd been admitted under observation as an outpatient. Now, because I take three different maintenance medications that are not related to that fracture, I was charged for those meds. By the way, with my prescription drug plan, these meds are so cheap that I have no copay for them. So I was given a total of 5 pills over the course of 3 days. I was charged $990 by the hospital. So this was not okay. The reason I spent 2 nights and 3 miserable days in the hospital was because the medical staff screwed up. And now they were charging me nearly $1,000 for their mistake. So I got my orthopedic surgeon involved. He contacted the hospital on my behalf, and the charge was waived. Honestly, I think everybody was afraid of litigation. But the point is, never hesitate to challenge things when you think that something isn't right. So I've spent a lot of time on this topic because I think it's a really important one. Observation status can have a lot of ramifications, and it's blindsided so many people with serious financial implications. So, because of this observation issue, Medicare adopted a new policy in 2017. So now a hospital must formally notify patients who are admitted under observation. They must provide written and verbal notice within 36 hours of the hospital stay to any patient who is admitted under observation status. And this is known as the Medicare Outpatient Observation Notice, or the MOON form. And the document specifies how observation status can impact hospital coverage and how it can impact Medicare's payment of aftercare services, such as skilled nursing. Now be careful. The hospital may relay this information to the patient, but not the family caregiver, even though the CARE Act says that they must. And the form may get lost in that massive pile of paperwork that gets shoved under our noses upon admission. Or, as in my case, the hospital never gave us one of those forms. And 36 hours may be too late. You will have already missed one of those 3 midnights necessary if you're discharged for post-acute care. So as a care partner, you have to be vigilant in asking about this. So I'm just going to show you what the form looks like. Again, I know it's teeny tiny on your screen, but it's a 2-page form with lots of text on it. I have a link on my website, so you can download a copy of this form if you would like to. So this is a template that Medicare has, and each facility is going to add their own information. Now, the form states that the patient is admitted under observation and the reason why. It then states how this status will impact the patient financially, including increased costs for medications. It also states that Medicare's ability to pay for skilled nursing care is impacted. They're going to ask the patient or the family caregiver to sign the form, but they don't tell you what you can do because technically you cannot appeal this. But as I mentioned previously, try to get your primary care physician to work with the hospitalist or the hospital to change the status. So during the admission process, and then again prior to discharge, the hospital must provide all Medicare recipients with a 2-page form called An Important Message from Medicare. And this form explains your rights, including the right to receive all necessary hospital care as covered by Medicare or your Medicare health plan. You must be informed of all decisions relating to your hospital stay made by the hospital and your Medicare health plan, and importantly, what services and procedures are going to be covered. Sometimes prior to discharge, the case manager should let you know what your insurance will cover, including medications and copays. The form also outlines your right to appeal a discharge and gives you instructions about how to file the appeal. And lastly, The hospital must arrange for all necessary services, such as home health care and special medical equipment, upon leaving the hospital, and they must tell you who will pay for those and how to get them. Okay, another teeny tiny little form for you to look at. This is what it looks like. And every hospital, again, is going to put on their own logo and contact information. Your rights are listed, including your right to express concerns about the quality of your care to an independent reviewer. Now, in California, the organization is called Levanta, and their phone number will be on the form. I put it on my example form in big red letters and numbers. So Levanta is responsible for medical case review. And these rights include making sure that you get the healthcare services that the law says you are entitled to. This quality care organization can help you if you have a concern about the care you've been receiving, or if you want to request a review, in other words, an appeal of your discharge from a healthcare facility. The form includes your rights in appealing a discharge and how to do it. We'll look at this more in just a moment. So the last step in a hospital stay is the discharge. Medicare states that discharge planning is a process used to decide what a patient needs for a smooth move from one level of care to the other. And only a doctor can authorize a patient's release from the hospital, but the actual process of discharge planning can be completed by a social worker, a nurse, or a case manager. The generic term to remember is discharge planner. So for the sake of simplicity today, that's the term I'm going to use. Ideally, and especially for the most complicated medical conditions, discharge planning is done with a team approach. Patients are evaluated by their physicians and specialists and any therapists who've been involved in care. This information is discussed with the patient and family caregiver. The discharge planner is going to work with the patient and the family to determine if the patient can go home or if he or she will need to go to a care facility. The staff must explain to you their recommendations for after discharge care. And as the family caregiver, be sure to communicate clearly to them your capabilities, your limitations, and your wishes. If you are unable to provide care at home for whatever reason, make sure that you state that. At a minimum, this discharge planning must be done and discussed with the family at least 24 hours before the day of discharge. Remember, it's your right to ask when discharge is expected, because you need to do some planning on your end. With my mom, I got in the habit of asking every day. They were probably annoyed, but that's okay. So most people who are discharged from the hospital are going to need some type of care afterwards. Decision-making about post-acute care can be challenging for everyone, but this can be even more daunting for the elderly or those with complex medical needs or cognitive impairment. Families often struggle to determine what care agencies or facilities are best for them. And sometimes it's not easy to find the right placement due to lack of availability. Adding to that uncertainty are insurance constraints. You may have to find a facility or an agency that's within your provider's network. And this can be the case for those who have a Medicare Advantage plan. And something else that I learned recently, sometimes the provider network is specific to the county in which the patient lived when they obtained their insurance plan. So a caregiver recently shared with me a problem that her family encountered. Their elderly mother resided in one county when she enrolled in her insurance plan. But due to some medical conditions, while later she was no longer able to live in her home, so she temporarily, or thought temporarily, moved in with a daughter who lived in another county. She didn't know that she needed to change her insurance. A couple of years later, the mom was hospitalized due to a fall, and needed to be discharged to a post-acute care facility. But instead of being able to be in the facility that was close to her family so that they could provide support for her, her Medicare Advantage plan would only cover her if she went to a facility in the county in which she had originally purchased her insurance. So, a little thing that I was not aware of until this was brought to my attention by one of my caregivers. So also some plans have benefit limits, such as how many days are covered. So while discharge planners make every effort in developing safe and appropriate discharge plans, the ultimate decision is placed on families and patients. And again, within the restrictions of the insurance provider. So this time-sensitive process, it must often be completed within 24 to 48 hours, which can overwhelm sick patients and their families, especially during a medical crisis. Now, you do have the right to appeal a discharge if you feel it is unsafe, and more on that in just a moment. Now, there's a variety of permutations regarding aftercare options. I'm just going to talk really briefly about the most common ones. Patients who don't need round-the-clock skilled nursing care may be discharged home, either their own home or sometimes the family. If they're able to go home, they may require support from a certified home health agency. The physician will usually be the one to order home health care, depending on the needs of the patient. But home health care is not 24/7 care. It's designed to be intermittent, maybe 2 or 3 times a week. And the patient needs to be homebound, meaning that it's not possible for them to go to a clinic or a rehab center for care. Medicare pays for all skilled services from healthcare professionals, so that's a good thing. Now, of course, we want to be able to look at what the caregiver is able to do. We want to look at the supplies that are needed and whether the home environment is a safe one. Usually a nurse from the home health agency will make a preliminary visit to check on home safety and make recommendations for modifications, such as installing stability bars in the bathroom or removing throw rugs, getting rid of clutter that may prove to be a fall risk, making sure that the lighting is adequate. They'll want to be sure that the caregiver has the help needed, either from family and friends, or they may need to hire a personal care agency. Personal care is not covered by insurance. It's very expensive. It's typically in our area, in the East Bay area, it's typically about $40 an hour. And so around-the-clock care, if you want somebody 24/7, it typically costs about $1,000 a day. Now, as the family caregiver, you don't feel you're able to provide care at home, you may want to ask the doctor if an order for a skilled nursing facility is possible. Only the patient's physician can give an order for skilled nursing. Those who are recovering from a stroke, a surgery, or serious injury may need intensive therapies that can be provided at an acute rehab hospital. Okay, that's another option after discharge. All of these services are covered by medical insurance. That's the good news. And the patient will stay at the rehab hospital until it is safe for them to go home. And the last typical option is discharge to a skilled nursing facility. It's a fairly common option for the elderly who need some type of round-the-clock medically necessary care. Hospital staff must provide lists of options, but it's up to the patient and their family to choose specific agencies and facilities. And this is done to avoid any conflicts of interest in case the hospital has any financial ties to the agencies or facilities. Most patients and families wouldn't mind having some help. Most of us aren't familiar with what's available in our area or which facilities are safe and good. But since federal law and regulations guarantee that you have your choice of where to go and which agencies to use, hospitals are restricted in the amount of guidance they can provide. Although it's been my experience that some facilities are pretty heavy-handed in recommending an agency with whom they have an affiliation. By the way, if you receive services from a home health agency and you are not happy with the care, it is your right to switch agencies at any time with no insurance penalty. Sometimes prior to discharge, the discharge planner should let you know what follow-up care your insurance will cover, including medications and copays. The discharge planner has access to all of your insurance information. Now, this may be a good time to make sure, again, that the hospital has your accurate and up-to-date insurance policies. Be sure they've done something called running your insurance. And this is a term that means they've checked your policies online. A list of medications is one of the most important components of the discharge order. If there are new meds, the discharge planner will either fax orders to your pharmacy or will give you the prescription. The discharge planner must go over the entire meds list with you and provide instructions. Remember, the discharge planner knows what kind of insurance you have. And if a particular medication is either not covered by your insurance or has a high copay, be sure to ask the discharge planner if there are any coupons. The other thing you can always do is ask your primary care physician if they have any samples, because sometimes that can help out a lot. If the patient is going to be going home, the hospital staff must train the family caregiver to perform any necessary tasks. Remember that CARE Act we talked about a while back. This training can be done in person, in written form, or by video. It all depends on how complicated the training is. Your loved one cannot be discharged home until the hospital is certain that the family caregiver is able to provide adequate care. The discharge planner will let you know if the doctor has ordered that the patient needs to be seen by a home health agency, and if so, again, we'll give you a list of agencies from which to choose. The discharge planner will send the doctor's order to the agency you've selected, and that agency should contact you to set up appointments. But remember, if the word health is there, then that means your insurance will cover the costs. All costs, and typically 100%. If the patient needs any special medical equipment, devices such as walkers, wheelchairs, crutches, maybe even a hospital bed or a bedside commode, the discharge planner will let you know where you can get that and if your insurance will pay. Again, they usually do. There are companies that will drop off the equipment and then they'll pick it up when it's no longer needed. Now, regarding follow-up appointments or tests, it's really important that patients be seen by their own physicians within 7 days of discharge. The discharge planner should contact the physician to provide information about the hospital stay, and then the family follows up to make the appointment. Again, the discharge planner should make the initial call, but it's your responsibility to actually make the appointment. So don't delay in doing this. It's your responsibility to ensure that any physician or specialist that the patient sees after a hospital stay accepts their insurance. You can't assume that just because your discharge plan says, see Dr. Smith, that Dr. Smith takes your insurance. Now, Dr. Smith's services may have been covered by your insurance while you were in the hospital, but your insurance may not cover Dr. Smith when you're an outpatient. Then you're going to be stuck with the bill. This happened to my husband. We appealed it saying, wait a second, Dr. Smith was listed in the discharge orders. So how are we to know any differently? But we were told that it is the patient's responsibility to confirm that the doctor is in the network. We even filed an appeal, but it was denied. If you have a Medicare supplement plan, you don't really have to worry too much about this. But Medicare Advantage plans tend to work like HMOs, so there can be out-of-network costs. I went over the discharge process in the previous slide, but Medicare has established that the patient's family caregiver has certain rights. And these are important, so I really just want to review them for a second. You need to be told the expected date of discharge, remember, at least 24 hours prior. The staff must explain their recommendations for after discharge care to you, not just hand you a stack of papers and say, hey, here, read this. If there's anything you don't understand, you really need to ask. You have the right to be involved in choosing where your family member is going to go after discharge. Remember, medical necessity may dictate if it's going home or to a facility, but you have the right to choose which facility, but again, double check on the insurance coverage. You can't be forced by the hospital to go to a facility that is not in a good location for you, or a facility that you don't like for whatever reason. If the patient is on Medicare, the facility must be Medicare approved. Most of them are. If the patient is on Medi-Cal, it must be Medi-Cal approved. And I'm going to guess that probably about 90% are, but not all of them. So check. And if the patient has an HMO or Medicare Advantage plan, remember, it must be in network. The patient cannot be forced to leave the hospital until an appropriate placement is located. This would be considered to be an unsafe discharge. Now, depending on what the medical team's recommendation is, the discharge planner must give you a list of possible facilities, home health agencies, and/or personal home care agencies. But again, they can't make any, or they're not supposed to make any referrals. And it's up to you to check out the options and make the phone call to arrange for services. Now, I have a link to Medicare's Care Compare tool on my resource list. It's excellent and it's really easy to use. And lastly, you have the right to appeal the discharge. And I'll tell you more about that in just a minute. But first I wanted to show you this. Everything I just said about the discharge process may sound like blah, 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 blah to you right now, because sometimes it's hard for us to process and digest information that we don't need immediately. So I have several sites for information about discharge planning on my resource list for when you need this information in the future. My two absolute favorites are Next Step in Care, and I spent some time talking about that one a few slides back. And the other one is Medicare's Discharge Planning Checklist, and that's the one I have up here on the screen. I have the link to that booklet on my resource list, and it is excellent. This slide shows you the first couple of pages of I believe it's a 6-page booklet, and I just wanted to give you a quick sense of what that looked like. All right, appealing that discharge. Sometimes the hospital creates a discharge plan that you do not want, that you don't agree with, or that you feel is safe for your situation. So you have the right to appeal this decision. However, before you formally appeal the process, it's just always good to talk with a doctor or the hospital's medical social worker or the discharge planner. Express your concerns, and hopefully they can adjust the discharge timeline to better meet your needs. By law, the hospital must let you know how to appeal, and they also have to explain what will happen. This is true for patients under the age of 65 and also for Medicare patients. So again, I'm going to assume that most of you are caring for a loved one on Medicare, so I'm going to talk about that process. Now, the important message from Medicare form describes the appeals process. I showed you that a few slides back. Should you choose to file an appeal while awaiting the decision, you can stay in the hospital without paying. Of course, you're going to have to do co-insurance and deductibles. Now, the magic words to use when you're appealing a discharge, say that you feel that this discharge is unsafe, and explain why. Here's that Medicare form again. Remember, this is the form that lists your rights, and it gives you the steps for appealing a discharge and what the timeline is. Don't miss the deadline, and you've got to act really quickly. The most important phone number, again, is that Levanta number, again, when we're in California. And you can start the appeal process simply by calling that phone number. Okay, so now your loved one's been discharged and is receiving home health services, or is in outpatient rehab, or is in skilled nursing. Medicare pays for all of that, but they have guidelines for when they will pay and when they will stop. Medicare must inform you in writing that they will no longer cover any of these services after a certain date. They'll send out a form that's called Notice of Medicare Non-Coverage. You have the right to appeal their decision to stop coverage, and the form is going to give you all of the details, including what you need to do to get an immediate appeal. The timeline is tight, and you must make the phone call to Levanta. Remember Levanta, again, if you're in California, before noon on the day that the services will no longer be covered. If your appeal is denied, the services will not be covered by either Medicare or your Medicare Advantage plan. Now, this form is different from the important message from Medicare that details your rights to appeal a hospital discharge. And here's what that form looks like. They kind of all look the same, don't they? So all of your rights and responsibilities are listed on this form, and it will include the phone number for the Quality Improvement Organization. There's our friend Levanta again, and all of the details you need. If you miss the deadline for filing an immediate appeal, it even gives you another option. Again, this form tells you that Medicare will no longer pay for home health, for rehab, or skilled nursing, and why, and how you can appeal the decision. I have links, as I've mentioned so many times, but I have links to all of these forms on my resource list in case you want to take a closer look. So let's say that Medicare has sent out their notice of non-coverage, but you disagree with their decision. Now, in the past, if a patient, either at home, in a skilled nursing facility, or in an outpatient clinic, did not appear to be making any progress with the treatment that they were given, then Medicare would stop paying for the treatment. This was not good because most people would decline after treatment was stopped, and in many cases would end up needing even more care. A class action lawsuit was filed against the federal government, and the plaintiffs won. So what's known now as the JIMO settlement was approved in 2014. Again, it used to be that if a patient was no longer making any progress, in other words, they'd reached a plateau, Medicare would not continue to pay for care. But the JIMO settlement changed all of that. So now, if a patient needs skilled home health care or outpatient services such as physical and occupational therapy, in order to maintain their current condition or prevent decline or deterioration, coverage cannot be denied on the basis of potential for improvement or restoration. So the JIMO settlement stated that Medicare skilled health coverage is not just a short-term acute care benefit. Under the law, Medicare beneficiaries who meet the qualifying criteria are eligible for skilled health services as long as this type of care is reasonable and necessary. Now, what I have learned over the years, even as recently as a few months ago from my caregivers that I work with, a big chunk of healthcare professionals are still not aware of the JIMO settlement. So I have a link on my resource page that you can use to help you if you need to appeal if services are being discontinued due to what they're saying is a lack of progress. So let's take a look at some organizations now and individuals who can help you to be an effective advocate for your loved one. The Beneficiary and Family-Centered Care Quality Improvement Organization, they provide medical case review and are the organizations that you can call if you want to appeal a Medicare decision. But you can also call them if you feel that you're not getting proper care. These organizations vary from state to state, but in California, the organization's name is, you got it, Levanta. You can start the appeals or complaint process simply by calling this 877 number. And as we've seen several times already, Levanta's number must be listed on any Medicare form in California that the hospital gives you. So 3 excellent nonprofit advocacy organizations are, first one listed here is CANNR, California Advocates for Nursing Home Reform. This is probably my favorite advocacy organization. The information they provide is not just for those in nursing homes, but for pretty much every aspect of elder care and rights. Their website is full of excellent and up-to-date information about everything from Medi-Cal eligibility, to all types of care facilities. They have legal experts on staff to answer your questions. I've used this service many times, either by a phone call or leaving them an email request. They always respond within 24 hours, and they always follow up to make sure that my issue has been resolved. If you've attended any of my past presentations, you know that I always mention CANNR. The next one is the Center for Medicare Advocacy, and they provide comprehensive legal analysis, education, and support for individuals and families. And then the Medicare Rights Center is a national consumer service organization that works to ensure access to affordable health care for older adults and for people with disabilities. I used all 3 of these nonprofit organizations in doing research for today's webinar. All right, long-term care ombudsmen are advocates for residents of nursing homes or for those who are residing in board and care homes and assisted living facilities. Ombudsmen can provide information about how to find a facility and what to do to get quality care. They're trained to resolve problems, and they can assist you with any complaints that you might have. So you can find your local ombudsman by entering your zip code on the website that I have listed here. It's also on the resource list. Long-term care ombudsmen don't help with hospital issues, but they're going to focus on issues with long-term care facilities. So every nursing home, assisted living facility, or board and care should have the local ombudsman contact information posted. And I talked about the hospital patient relations department earlier. So every hospital should have one of these departments or have something called a hospital privacy officer. So these are individuals or teams that objectively handle patient issues and complaints. They conduct internal reviews. If you have a complaint, ask about how you can contact the patient relations department. And then another excellent resource for patients is the medical social worker. When my mom was admitted to the hospital so many times, I would always ask for the name of the social worker on the floor that she was on. These social workers have special training to work in medical facilities. They can also, as I mentioned earlier, act as a discharge planner. This varies from hospital to hospital. Honestly, I can't tell you how many times the hospital social worker has come to my rescue. So let's say you're not happy with some aspect of care. How do you file a complaint? First of all, it's always best to contact the facility or the agency and let them know what the issues are before you file a formal complaint. Let them know that you have a formal complaint and that you intend to file it. This generally gets their attention and motivates them to make things right. In most cases, you can file a complaint anonymously, but it's actually better if you provide your name and contact info, and that way you can be contacted should further information be needed. And always be sure to keep as much documentation about your concerns as possible. This can include email and text messages, voicemail messages, actual paperwork that you've received, and even notes that you've taken about the situation. Here are 3 agencies that may be able to handle your complaints. And all 3 of these have convenient online reporting forms as well as phone numbers. All of this information is included on the Community Care Licensing online complaint form that's provided by the California Department of Social Services. And this form is primarily for complaints about facilities that serve older adults and children. For complaints regarding Medicare or Medi-Cal fraud, you can file an online complaint with the U.S. Department of Health and Human Services. This reporting system covers healthcare fraud, quality care issues, and medical identity theft. You can either complete the online form or call the number listed here. I mentioned Canner in the previous slide. They also have an online form for asking questions and filing complaints. So don't hesitate to voice your concerns. You'll not only be helping yourself, but you're going to be helping others in the community who may have had similar unsatisfactory experiences. All right, I know I've gone over time today, but in conclusion, I want you to remember that you are a really important member of the care team. Do your best to be prepared, to be organized and assertive. Always do your research or take advantage of mine, and be an informed consumer of healthcare services. Know your rights, stand up for them, and advocate for your loved one and yourself.